All right, back to you, Remy.
Okay, yeah, so if you don't know, yesterday was French National Day, and as a coincidence, our speaker today is from France. So it's my pleasure to introduce Dr. Simon Cauchemez from the Pasteur Institute in Paris. So Dr. Cauchemez guy is PhD at Pierre-Marie Curie University in Paris before moving to Imperial College and spending 8 years there. So that's where he started his work on analysis and assessment of the risk of emerging infectious diseases. That's where he worked, for instance, on influenza H1N1 in Southeast Asia, MERS, SARS, and 2009 H1N1 influenza pandemic. As part of this work, he was one of the main creators of the APS-team package in R that a lot of us have used. It makes it easy to estimate the basic reproduction number of an epidemic just using time series cases. So thank you for that. And another aspect of his work has been on the evaluation of the impact of interventions on transmission. For instance, he has a cool paper estimating the impact of school closures on influenza transmission using case data and school holidays in France. And then in 2013, he moved on to the Pasteur Institute in France, where he created and is heading his mathematical modeling of infectious diseases, multidisciplinary team. So he's continues work on emerging diseases, now working on Zika, chikungunya, and yellow fever, among others, and also more established diseases. He's been helping inform public health agencies in France and abroad regarding best responses. And his group has also been very busy this year. Their regularly updated forecasts on the course of the epidemic in France has helped inform the French public and guiding the government through the pandemic and whether to trigger lockdown or not. So I think today is going to talk about the Pfizer vaccine and isolation. So I leave it to you.
Thank you, Remy. And I feel I need to start with an update on the French situation since it's where we are. So we were very happy with the situation till recently when Delta arrived. And Lauren, I don't know if what you presented now, you just have Delta or is it?
We don't know. I mean, the recent estimate from the CDC, and correct me if I'm wrong, group, is that maybe a third to a half of cases in Texas, so not specifically in Austin, and there's a lag in the molecular data are Delta. So we have a good bit of Delta at this point.
Okay, because so we had a controlled epidemic till very recently, and Delta has completely changed that matter. I was very surprised, to see just now we have doubling times of just 5 days, and we moved from 2,000 cases, 2,500 cases across France to now 9,000 in a very short interval. And so our projections have completely changed, and the increased transmissibility we have currently is more like 200-300%. So the others have reproduction numbers of 0.5, effective 0.7, and Delta right now in France is about 2. So it's really very surprising. And so just a couple of days, the president has said that now we would have a sanitary pass where if you want to go to the restaurant, you'll need to show a QR code saying that you are vaccinated or that you had the test in 3 days. Which, well, I don't know how that would work in Texas, but even in France, it's already difficult. But people after that, people have started that there was a slowing down of vaccination, and suddenly everybody is booking their appointment for vaccines again. Okay, so I will.
What is the culture around wearing face masks?
We never had problems with face masks. So I mean, it was and actually it has been mandatory for also outside for a very long time, and it just last summer actually became mandatory. Or September, and initially they wanted to have it mandatory just in some areas outside, like in markets and all that, but it was getting very complicated because you in Paris you would be in a street, then you need the mask, then you don't. So it was simpler to have it mandatory everywhere, and it just at the end of June that we stopped mandatory use outside. And that has never been a big problem with face masks. Like more lockdowns and that kind of things have been more challenging, but face mask has never been really an issue.
One of the reasons I'm asking is because we are also seeing, a dramatic increase in the reproduction number and transmission rate, but we simultaneously, we've had Delta come in, and we've also thrown away our face masks. So it's hard to know, because we also sort of stopped wearing face masks a couple of months ago. So I'm curious if you can disentangle how much is behavior.
I mean, we have the surveillance that, like the proportion of the different of Delta and not Delta, and so I can show you the graphs. But Delta there's a big surge in Delta, and the number of cases of the other variants are declining. So in the French context, at least, and the reproduction number is not 2 yet, because Delta started from very low and increasing very quickly, but it will, it's changing so quickly that soon we'll just have like a big proportion.
Yeah, and we've estimated that it's increased from about 1 to, and correct me if I'm wrong, group, but to like 1.7 at this point locally, reproduction number.
Yeah, okay. Okay, so I'll talk about work that we've been doing with with colleagues in Israel from the Sheba Medical Center, as Remy said, looking at the impact of the Pfizer vaccine and also isolation on SARS-CoV-2 transmission in Israeli households. So we already have a number of estimates of vaccine efficacies, in particular the efficacy in reducing the risk of infection, the risk of reducing the severe symptoms. There are also data on the impact of vaccines on transmission, but they are more limited because it's just harder to estimate, because to do that you need to properly be able to document transmission events, and that's a bit more challenging to do than just a follow-up of people where you see who is infected and who is not. And a nice setting to assess transmission and the impact of vaccine on transmission is households, because there you have high contact rates, so high transmission rates, and it's relatively easy to document likely transmission events. And so we looked at, we tried to estimate the efficacy of the Pfizer vaccine in Israeli households. And as you know, Israel has done very well in terms of getting very quickly their high vaccine coverage in their population. And so we benefit from these like early Israeli data. And so our colleagues did their study in a large medical center in Israel that has about 12,000 healthcare workers. And so the design was that they would ask these healthcare workers to inform them of any SARS-CoV-2 case, either so in the healthcare worker or in their family members. And that way they were able to identify a bit less than 300 SARS-CoV-2 cases, either in the healthcare worker or in their family members. And so the study was from January to end of April of this year. And so like 60 families did not want to contribute to the study. And so we had follow-ups of about 200 households. And of these, like there was with about a bit less than 700 household contacts in these households. And then we lost like 2 households because the data was some data was missing. And so then the design was that when a family was recruited, everybody would get tested with a PCR test at inclusion, and then in the 10 following days. And there was also a phone interview where they asked standard questions about vaccination status, prior infection, symptoms, and also whether people isolated from the index case. So you can see here the characteristics of the index cases on the left and on the household contacts on the right. So there were, if you look at the index cases, there were a bit more women in this group. And so out of about 200 adult or teenager index cases. Not so many were vaccinated, only 15, so 8%. And at that time, there was no children were not vaccinated in Israel. Most of these index cases were symptomatic, like 90% in the adult teenagers and less, like 40% in the children. And now for the household contacts, about 25% of them were vaccinated. And they also had large proportions that did isolate, either partially or totally. And so the isolation in this study was defined as you're not eating nor sleeping with the case, and you don't share a bathroom. So about 70% did implement like a isolation in adults, teenagers, and in children that was a bit less than that. About 50% of them did isolate. So that's the secondary attack rate estimated for different groups. So the proportion of household contacts that did get infected. And so in this study, actually, the secondary attack rates were very high. Like on average, it was 40%, so substantially higher than other studies. And at the time, like that was the alpha variant that was circulating. And you really see like a very strong gradient of the secondary attack rate for, depending on the group of contacts you're looking at. It's about 75% if the contact is an adult that did not isolate and was not vaccinated. It drops to 27% if the contact is isolated but not vaccinated. About same value if the contact is vaccinated but not isolated. And then a further reduction for vaccinated individuals that also isolated. And in children, you also have very high secondary attack rates that are divided by about 2 if the child did isolate. And then the other way to look at these secondary attack rates is to estimate the proportion of contacts that got infected if the index was vaccinated or if he or she wasn't. And so you can see a reduction of twofold for the secondary attack rate in vaccinated contacts when the index case was vaccinated. So of course, these are just univariate estimates, and we know like all these different drivers they are confounding effects. So we want to develop a multivariate approach to be able to estimate the impact of vaccination status of the infector and the age, isolation behavior, and vaccination status of the infectee on the risk of transmission. And that's what we did here. And the big challenge in that kind of study is that even though you have a relatively detailed follow-up of the household, there are still things that you don't get and that you need to perform inference. So typically, you're not sure who was infected by whom. You could have people that contacts that were infected outside the household or that were infected by a case that wasn't the index case. And so you need to capture for these different possible like routes of transmission. And that's what we do with methods that are not now relatively standard in the field, where basically we are going to, so we use a Bayesian statistical framework, and we say we are going to augment the data with the key quantities we need to perform inference. And here that's the dates of infection of the different cases. And then, so these parameters are considered as nuisance parameters, and then we can explore the joint posterior distribution of the parameters we're interested in, and these dates of unobserved dates of transmission we need for inference.
Can I ask a question?
Sure.
Sorry, going back one more slide. So just what do you mean by the isolation behavior of the infectee? Are you saying in a household you have a case and then you're looking at whether the other people protect themselves from the case as opposed to whether the case themselves isolates?
Yeah, I mean that's how I think that's how they perform. That's how they ask the question. Like, would you share a meal with the infector? So they ask the question to the infectee and not to the infector, which I agree somewhat. I guess it depends how people were, but I guess they did that because if you look at these behaviors, you have, when you look at the contacts, actually the children contacts they did not respect these rules as much as the adult contacts. So it make, if in the household a contact will there will be isolation with some household members, but not all of them. It makes sense that this is a property of the contact rather than the property of the case.
I understand. So it is sort of what the case is doing, but it's its effect on the contact in a sense.
Yeah. It's,
okay.
It's captured with the contact.
I got it. Okay, thank you.
Okay, so then, so just like I mean, these are standard types of models, right? Your hazard of infection in the household at a given time point will be the sum of the risk of infection in the community, the hazard of infection in the community, and then the sum of the forces of infection exerted by each household member. And of course, these beta I will depend on, so again, the characteristics of the infector or of the infectee, and also in practice here it can stand, but we say it will vary over time with the infectivity of profile of the case. So our assumptions when we look at symptomatic cases are relatively standard or the natural history of infection. So we assume, and these quantities, we do not estimate them from the study, but take them from the literature. An incubation period of 5 days, and you can see the distribution here. And then an infectivity profile that for these symptomatic cases, we will say is dependent on the date of symptom onset. And then for the asymptomatic cases, it's a bit more challenging because, for the symptomatic cases, we have the date of symptom onset that is like the date we use to define when they will be most infectious, for example. But of course, for the asymptomatic cases, that's more tricky because we don't have a date of symptom onset. All we have is a positive test. And so here we make the assumption that these cases shared for up to 10 days. And so their date of infection can be any time in the 10 days before the detection, the PCR positive result. And then we'll say the infectious period will start 2 days after infection and peak 5 days after the date of infection, which is a way to try to capture the uncertainty we have about their infectivity profiles. And then in our baseline scenario, we assume that they are 40% less infectious than symptomatic cases. So these are our results. So first, the first graph is looking at the relative susceptibility, where the reference group is adults that contacts that did not isolate and were not vaccinated. So that's reference one. So you can see first children are, we estimate, and children here as defined as being less than 12 years old. And so we estimate that they are 50% less susceptible to infection than adults. And then you can see that isolation really has a huge impact on the risk of transmission, a reduction of almost 85–90% in adults, and also quite a big reduction in children. Then if we look at vaccinated adults, we find, and their risk of infection, we find that it's reduced by about 80%, thanks to the vaccine. And we also, there's a signal that there's a further reduction when these individuals isolate. although you can see that we have some overlap in our credible intervals. And then for the reduction in infectivity, we have quite high estimates of with almost 80% reduction in infectivity in vaccinated individuals. And I didn't mention that, but actually vaccinated here means that it's at least 7 days after the second dose. That's our definition for being vaccinated. So big reduction, but you can see also large credible intervals, which comes from the fact that we don't have a lot of vaccinated index cases. Again, it was only 15, so clearly a relatively small sample size. And this is just,
sorry, I'm just one more time. You probably said this at the very beginning, but were all the index cases adults?
No, but all the vaccinated index cases were adults. So if we look back at we had
okay,
24, so most of them were adults. We didn't have a lot of, so we were not able, for example, to assess whether kids were less infectious than adults, because we didn't have the power for that. So this is just showing like some numbers of this time, not the relative reductions in risk, but the overall, how the person-to-person probability of transmission is estimated to change in a household of size 4 for the different like categories of whether your index case is vaccinated or not, and then what is the profile of the susceptible individual. And so you can see clearly a broad range of values. So we did quite a lot of sensitivity analysis to see how estimates would change with modeling assumptions. I'm not going to go in the details of each of these, but you can see the estimates were relatively stable, like clearly some small variations, but I don't think like the key messages would change, like whatever the scenario you look at. So quick conclusion. So we estimate a reduction in the risk of infection after the 7 days after the second dose of about 80%, which is a bit less than some estimates in the general population, but consistent with the other studies in households. And here there might be, potentially the fact that in households you have higher exposure, so maybe it may have an impact on these estimates. We also get big reductions in the risk of transmission, but with a relatively large credible intervals. And then the other like interesting results about these isolation behaviors, where we find a very big impact on transmission. And there's a signal that would need to be confirmed that that even in vaccinated individuals, there's a benefit in isolating.